I'd like to welcome you to today's virtual health talk. We've started this series since we are not able to come out to you in your communities anymore, but now we can come even closer into your homes and businesses through these virtual health talks to still get you the information you need about your healthcare. You'll notice at the bottom of the screen there's a Q&A button. That's how you'll submit your questions for today's presenters. We'll hold the questions to the end of the talk. They will go through their presentations, may answer your questions that way, and then you can answer your question, ask and have your questions answered at the end. There is an anonymous button if you choose not to have your name presented with your question. We'll also be recording today's talk, and it will be saved on our website. And later this week or early next week, we'll get a follow-up email that will have a link to the talk if you'd like to watch it again and or share it with friends or family. You'll also have the contact information for our presenters in that email. So without further ado, I'd like to introduce today's speakers. We have Dr. Erin Loeb and Anna Myers, certified nurse practitioner from our urology department. Anna Myers has worked in female urology since 2010. She graduated from the University of Cincinnati in 2013 as a women's health nurse practitioner, obtained board certification in urology in 2016, and family nurse practitioner in 2018. She serves as president of the Great Lakes Northeast Ohio chapter of Society of Urologic Nurses and Associates. She enjoys caring for men and women, and she has special interest in treating urinary tract infections, urinary leakage, female sexual health issues, frequent vaginitis, and genital skin issues. She sees patients at Parma and Westlake, and she enjoys walking in the Metro Park with her husband and watching Netflix reruns with her college and high school age daughters. Dr. Erin Loeb is also an assistant professor at the University of Case Western Reserve University. He has a fellowship in male sexual dysfunction from the University of South Florida College of Medicine. He did his residency and internship at Wayne State University School of Medicine and has a medical degree from Wright State University Boonshoff School of Medicine. He's also an undergraduate of the University of Wisconsin-Madison, and he sees patients in Lyndhurst, Parma, and Cuyahoga Falls. So without further ado, I'd like to hand it off to Anna Myers.
Hi there, my name is Anna, and we're excited to be here with you. We think the people that work on this, Linda Hammond Hadfield, Mark White, and Tyler Granger for putting this together for us and inviting us to be a part of this lecture series. So without further ado, I'm going to jump into the female urology part of this lecture. I like to talk about the physiology a little bit before I get started on the different issues that women deal with in female urology, because I think understanding the physiology of it helps to make sense of, why these things are occurring and also how the treatments work. So and it's a combination of issues that come together, but oftentimes we see that hormones can play a significant role in some of the issues that women deal with in female urology. Estrogen's role, it stimulates the maturity of the vaginal epithelial cells and accumulation of glycogen in those cells in the vagina. The glycogen, through chemical reactions, becomes lactic acid, and lactic acid makes the environment just right for something called lactobacilli, which is the good bacteria in our body. Lactobacilli have antimicrobial and anti-inflammatory properties, and along with an intact vaginal epithelial mucosa, this is a barrier to invading pathogens in that part of our bodies. This estrogen also helps keep the pelvic floor muscles healthy, strong, and elastic. So estrogen comes from the eggs in our ovaries, and when we're born, we have like millions of eggs, but as time goes on, we come down to menopause, we just have a few thousand. And that's where the main source of estrogen comes from for our vaginas. Genitourinary syndrome of menopause, or GSM. And this is terminology that you're going to be hearing more of in the coming years. It's already used in the literature and the research, and it's coming out on the next set of ICD codes for the billing. But this is talking about a collection of physiological changes. We have decreased blood flow to the vaginal epithelium with the lack of estrogen. We for that lactobacilli, and we have an increased vaginal pH. So as the pH increases, it becomes more basic, allowing more bacteria to be in that area. We have decreased epithelial secretions, and that causes more increased irritation, infections, and pain with intercourse. And the tissue of the bladder, the urethra, and the pelvic, they atrophy. And what do we have? Sort of a perfect storm. So a bunch of kind of combination of factors come together, and women are more risk for urinary tract infections, intimacy issues, urinary incontinence. And I have this one line down here about menopause, oral birth control, and breast cancer treatment, because menopause isn't the only time we see some of these issues come up with women. There's also vaginal changes due to the hormones when you're using oral birth control. So we see that in our younger gals. And then also with breast cancer treatment, they even call, like going through chemotherapy, they'll call it like a chemopause, because some women experience some of these same symptoms then. So first of all, you kind of want to, if you've had at least 2 urinary tract infections in 6 months or 3 in a year, that would warrant an evaluation by a urology provider to make sure that there isn't anything going on that can be treated, such as a kidney stone or a polyp, a tumor. We want to rule out the bad stuff, the cancers, that kind of thing. And then once we've evaluated you, we want to talk about prevention. So how can we prevent urinary tract infections? We want to be making sure that we pee every couple hours, so about 8 times a day. And we don't want to do that all in the morning. You don't want to go big long stretches without urinating, like 4 or 5 hours. You do at nighttime when you're sleeping, but during the day, you want to go every 2 to 3 hours. So drinking enough fluids that your urine is a clear to pale yellow. Managing your bowels. We know that most urinary tract infections, 90 to 95% of them are E. coli, and E. coli is in our bowels. So if you have constipation going on, then you're going to have more of that bacteria microscopically there in that vaginal area and putting you more at risk for urinary tract infections. Managing bowels can be something like just using over-the-counter psyllium fiber, which is what's in Metamucil. You can buy that as capsules, or using something like Colace or Miralax, over-the-counter products that are pretty mild, but very effective. Vaginal acidity. We talked earlier about the physiology of how with lack of estrogen, your acidity goes up, but we can change that acidity with putting a little bit of local estrogen there in the vagina, whether it's a cream a few nights a week, or we have rings or tablets. And there's also some over-the-counter products, Replens, Refresh, those are vaginal acidifiers, and we can try to change that pH and decrease the amount of bacteria there. Vitamin C daily, just 500 milligrams, boosts the immune system, and that's typically what you can find in like a multivitamin. And then cranberry or D-mannose, and I have to say that I find D-mannose is a real game changer for a lot of women. It's a simple sugar. You can purchase it over the counter in a concentrated form. It's either a capsule or a powder, but 2 grams of that daily is very helpful. It's what it happens is that it specifically is more interested in E. coli bacteria, but the E. coli bind to the D-mannose, and then they don't have a way of sticking to the lining of the bladder. So then when you drink lots of fluids, it gets flushed out. And that can be very helpful for women. Intimacy. We often see a lot of issues for intimacy with women as they age, and sometimes in younger women as well. And there's 4 areas that intimacy can be affected: arousal, desire, orgasm, and pain. And through evaluation and examination, we have tools that we can kind of help to tease out some of these issues. We have therapy and counseling that can be offered for patients. We also have ways to increase libido. There's vaginal skin issues that we can address. There's moisturizers and lubricants. Oftentimes women have heard about these products, but they don't really understand how they work. So moisturizers is something that you can use daily for maintenance. Lubricants are more for lovemaking. Pelvic floor physical therapy. We have some great pelvic floor physical therapists in our area. These are providers that have gone on beyond their physical therapy, and they specialize in the pelvic floor. and they can help with pain issues and determining if it's your spine or if it's your pelvis that the pain is coming from, and also with muscle issues. Dilators, stimulators, and FDA-approved devices. There's more and more research going on for women in intimacy issues, and there's now a couple of medications that are FDA approved to treat these conditions as well. I laughed so hard the tears rolled down my legs. So when I talk with women about urinary incontinence, oftentimes they readily recognize stress urinary incontinence, and that's the leakage that occurs when you cough, laugh, sneeze. It's due to decreased collagen and weakening of those vaginal walls. It could be related to surgery in the past, childbirth, increased weight. We walk on our feet, and so all of that is on our pelvis, and that can damage that area. And what can we do about it? Oftentimes women have heard about Kegel exercises. Those are taught when women are, after they've had children oftentimes, and then they sort of forget about them. But, if you are able to do those and you can practice them doing like 10 sets, 3 sets of like 10 of them a day, you have to kind of do them on a daily basis though, because when you stop doing them, it just goes back to the way it was. Just like if you're exercising your arm and then you stop doing your exercises, it just kind of goes back. Pelvic floor physical therapists, they are able to help women isolate those muscles to do Kegels properly, as well as providers such as myself. And that's because we know about 50% of women do not do them correctly. So you shouldn't be able to see you doing the Kegel exercises. Pessary, that is a silicone device. It's fit in the office and you can insert it in your vagina. So it sort of becomes a support. So if this is your bladder, imagine this is your urethra. If you cough and sneeze, if that urethra is not being stabilized, then little bits of urine or lots of urine can leak out. But if you have a pessary, which is sort of just like a ring that can be put there, that becomes the pressure against that urethra to keep you from leaking. And mid-urethral sling, that's the gold standard. It's been around for about 20 years now. It's not included in the mesh with the FDA warnings. And it's sort of like a little shoelace. It's kind of what it reminds me of. And your scar tissue grows into that mesh, and that becomes the support for the urethra. Will that be a window, aisle, or a bathroom seat? So this is the type of urinary incontinence that can be very debilitating for women. It can really change their quality of life. We've all been in that situation where we've kind of like waited too long or drank too much and gone on a travel. And so we know what that experience is, but there's some women that experience that all day long. And this could be due to neurological changes in the brain and spine, perhaps Parkinson's or MS, gravity shifts and irritation. Infections can cause inflammation and decreased capacity and more spasms. We can have damaged nerves, maybe from childbirth, spinal injuries, decreased estrogen, as we discussed before, weakens that bladder, urethra, and pelvic floor muscles. And what can we do about urge incontinence? So first of all, we want to look at behavioral modifications. So that first line treatment would be looking at what you're drinking. If you're drinking a lot of coffee, tea, or soda, it's not only the caffeine and the sugar, but the little carbonation in the soda can be very irritating to the lining of the bladder. We want to talk about bladder retraining. So there's tricks and techniques to retrain that bladder, because oftentimes we kind of put that off as women and take care of everybody else except for ourselves, and then we are dealing with these kind of issues later. Medications, we have a couple of classes of medications that we can use. I think this is where really the art of the urology comes in, because it's one thing to just say, okay, we're going to take a medication, but we kind of need to look at what are the other factors going on in your life. Are you struggling with constipation? Are you struggling with high blood pressure issues? Are you a type of person that can't take a daily medicine? You just can't add one more to the mix. And then lastly, we have procedures such as Botox injections, InterStim, and something called percutaneous tibial nerve stimulation, which is a mouthful. But Botox injections, we do those in the office and also in the OR. That those injections go into the bladder in certain areas, and we know that by paralyzing it, we can stop bladder spasms. So urge incontinence, what happens is normally as your bladder fills up, you have receptors on the inside of the bladder that tell the brain what's going on. And the brain sends back, oh no, this isn't the right time. You know, we're traveling, you're going to have to hold off, and your bladder's supposed to expand and your urethra stay nice and tight. But when it's time to urinate, your pelvic floor muscles relax, the urethra, the sphincters relax, and your bladder spasms, and that's how you're emptying your bladder. But when you have overactive bladder, you're getting that signal when it's not the appropriate time, and it's difficult to control, to overcome. We also have a bladder pacemaker called InterStim. It's a device that's been around since 1997. It's a battery with a wire. It's a very simple device. It's put in the backside, doesn't touch your spine, but it puts off impulses and changes the impulses to the bladder. And then lastly, PTNS, or percutaneous tibial nerve stimulation. And that's a procedure I do in the office, sort of like a little acupuncture. It's a tiny little needle, goes in the lower part of the leg, and I hook it to a little box. It puts off impulses, kind of like a fluttering in the bottom of your foot, but it actually travels up your tibial nerve, and that changes the impulses to the bladder. So wear dark pants only if you love them. So as I sit with women, you know, they know where all of the bathrooms are all over town. They can tell me, you know, how they have to take all these clothes with them. They take almost like, you know, bags of clothes with them so that they're always prepared. And they're always wearing black pants so they can keep from anybody seeing what they're dealing with. But I just want you to know, drizzle, flood, small amount, large amount, urinary incontinence is treatable and not something that you have to live with. Thank you.
All right. Well, I think it's my turn. Thank you, Anna. That was a great talk. And thanks everyone at UH for putting this together, and everyone for tuning in to join us here. Hope everyone had a nice Memorial weekend. Thanks Mark for the nice introduction. My name is Aram Loeb. I'm a urologist here at University Hospitals. My practice is kind of a hybrid between male sexual dysfunction and general urology. So I deal with a lot of erectile dysfunction, Peyronie's disease, but also just the other urologic issues. So BPH, prostate cancer screening. Here are some of my offices. I do have a website where there's some information, and we'll have all this available at the end as well. So for kind of his side of this conversation, I picked three big topics that I see a lot of. So BPH, which is kind of the enlarged prostate and the lower urinary tract symptoms that come along with that. I'm going to talk a little bit about prostate cancer, the screening, the diagnosis, and the treatment options. And then we'll also touch on erectile dysfunction, saying, you know, what are some of the causes? What are the things that are out there that you may or may not have heard of? So BPH, so benign prostatic hypertrophy. So, you know, the prostate is an organ that sits right underneath the bladder. And, you know, it's important in our sexual reproductive health, but after those years, it really just causes problems in terms of urinary symptoms as well as prostate cancer. So kind of the normal prostate, like I said, it kind of sits right underneath the bladder, and the channel of the urethra, which is the tube that drains the bladder, runs kind of right through that. And over time, as you get older, the prostate can grow, and it can kind of just decrease the size of the urethra, the lumen. I tell people all the time, I'm just a plumber. And it's all about kind of the flow. And if the pipe gets clogged, you know, your flow is not going to be good. It's going to be kind of a dripping faucet. And there's things that we can do to help out with that. Another thing that, you know, comes along with it, you know, it may be irritating that your stream's not good, you're not emptying very well, but this can also affect your bladder. It can thicken your bladder can become what we call less compliant, where it can't store as well. So you may be getting up more, maybe you're getting up a couple times at night, or you feel like you gotta go all the time. And eventually this can also affect your kidneys as well if this continues. So, you know, it's not something that you need to live with, or you really should live with, and it's something that should be addressed. So what are some of the symptoms of BPH? So that frequent urination, where you're just not emptying the bladder all the way. You say you went, and then, you know, 15 minutes later, you're sitting back on the couch and you got to go again. Getting up at night. A lot of times, you know, the men aren't bothered by this, but if you ask their partner, they are extremely bothered by this. So it doesn't just affect you, but you know, a lot of people say, you know, that's normal for my age. It doesn't have to be. You know, getting up 4 times a night, you're not going to sleep well. You're going to be groggy during the day. There's a lot of issues with that. Sometimes you have that sudden urgency where you feel like all of a sudden you got to get to the bathroom right away. And if not, you may have an accident. When you do go, you may finally get to the bathroom and then you have to stand there and wait and wait and wait. We call that hesitancy. And just until you can initiate the stream. The stream may start and stop and not be a good flow like you used to have. So those are kind of the classic signs of BPH. So how do we diagnose it? So if you came to my office, you know, a lot of times people have been seen by their primary care doctor before, they've been on some medications, and then they get sent over. But what we do in my office is, you know, when we were seeing, you know, when you come into the office, you know, AUA symptom scores, which is just kind of a survey that kind of goes over some of the questions I just talked about, you know, a thorough medical history. You know, sometimes medications can play a role, you know, past medical history, surgical history can play a role. The physical exam. So here's a picture of, you know, the classic digital rectal exam. You know, that's more for kind of prostate cancer screening. You know, when we feel there, we can kind of feel the outside of the prostate, and that's where prostate cancer tends to live. It doesn't give us a whole lot of detail about what things look like on the inside, but that is a role that, you know, it can give us some information about the estimated size of the prostate. We'll usually check a urine sample to see if there's any blood, any infection in there. We'll do what's called a post-voiding residual, where after you urinate, we can put a little ultrasound probe on your abdomen and see how much is left in the bladder. And it should be pretty empty, but for some guys, there's still a lot in there. You know, kind of some advanced testing that we'll do is sometimes a cystoscopy, where we look inside the bladder with a little scope in through the urethra, with the hole you urinate out of. And then I can see kind of the channel there and see if it's obstructed, see if there's any scar tissue, any stones, things like that. A prostate ultrasound is very good at getting a very accurate size of the prostate. And then sometimes we'll do what's called urodynamics, which is kind of a little more invasive testing of the bladder, and we see how it fills, the pressures that it exhibits when it fills, how it contracts, and kind of how your body responds to the filling and emptying phases of the bladder. So what are some treatment options? I mean, the goals here are to get you urinating like you're a teenager again. You know, get you, you know, not right now with the weather being so good, but in the winter, you know, I always tell patients they'll be writing their name in the snow. So what are some treatment options? So kind of the conservative things, you know, similar to what Anna had talked about. We'll go into some medications and then some minimally invasive procedures and other more advanced procedures. So what are the conservative options? So I tell all of my patients to double void. And what that means is, you know, go and urinate. And instead of kind of zipping up and going and washing your hands, you know, just wait 15, 20 seconds. Take a couple deep breaths, just relax, and then try to go again. Just kind of get everything else out. And then time void. So don't wait till your bladder or your body tells you you got to get there right away. You kind of dictate that. So 8 o'clock you urinate, 10 o'clock you urinate, noon. And kind of retrains the body to kind of help avoid some of those urgency episodes. Another big thing is avoiding the bladder irritants. I'm not saying you got to cut anything out. I, as a coffee drinker myself, I could never tell someone they have to cut out coffee, but know that caffeine, citrus, spicy foods, chocolate, alcohol, things like that can irritate the bladder and make you feel like you need to go more frequently. So, you know, a lot of times avoiding diaries, or just for a couple of days, just write down what you drank, and then when you urinated, how much you urinated. And a lot of times you look at it and you go, oh, I had 4 cups of coffee and I was running to the bathroom one morning. Maybe I should cut down on that. And that can be very helpful. And then another big thing is constipation. When we do our pediatric urology rotation, one of my mentors always said, your number 2 is our number 1. And that's very important in pediatric urology, but also in adult urology. Constipation can wreak havoc on your urinary system. So making sure that you're having regular soft bowel movements, not straining, because if you are constipated, it can really cause issues emptying the bladder as well. So what are some of the medications that are out there? There's really two main classes of medications. You have your alpha blockers and your 5-alpha reductase inhibitors. So the alpha blockers, that's your Flomax, your tamsulosin, things like that. You may have, a lot of patients already been started on this by their primary care provider. What this does is works to kind of relax that prostate and that bladder neck. So that picture I showed you where the prostate's right below, it just kind of helps to relax that. It works relatively quickly, usually about a week or so, and most guys tolerate it very well. It may lower your blood pressure a little bit, and make you kind of drowsy, so a lot of patients take it at night. One thing that you may see with it is what's called retrograde ejaculation, or kind of decreased ejaculate volume. It's really of no concern unless you're trying to have a baby, but patients can be really freaked out about it. It's good that they're aware that this may happen with that medication. The other class of medication, the 5 ARIs, they work to really shrink the prostate. They inhibit the conversion of testosterone to a more potent form within the prostate, and that's really what drives the size of the prostate. They can take a really long time for these medications to work. It can take up to 6 months. It does shrink the prostate, but there are a lot of side effects, a lot of sexual side effects, kind of cognitive side effects. So I don't use it a whole lot in my practice, but it's a medication that's out. This is the finasteride, dutasteride that you may hear about. So kind of moving on, what else is out there? So there's kind of this new class. I mean, they're new in, past 5-10 years or so, but newer in the overall grand scheme of things, of kind of minimally invasive procedures that we perform for the prostate to kind of help change the physiology, help you emptying better, preserve bladder function. So one of them is called the prostatic urethral lift, or Urolift. So this is an outpatient procedure. Can either be done in the office or in the operating room with a little bit of sedation. It's very quick. Our procedure takes about 10-20 minutes. Most often you do not need a Foley catheter. It preserves sexual function. So we'll talk about some of the more advanced things that may have issues with affecting your ejaculation, your erection, but very low incident of that with the Urolift. It's rapid. Most of my patients, I talk to them, a week later, they're already feeling that their stream's better, they're emptying better, they're not getting up at night as much. And like I said, most guys go home without a Foley catheter, which is important for a lot of people. It is a procedure, and it may require a little bit of sedation. I usually, the first kind of 3 to 5 days, may see some blood in the urine, may burn a little bit, but guys do really well. And I'll kind of show you, here's a kind of a diagram that kind of walks you through what this is. So these are little implants. It has a suture material, and what it does is it takes that area of the prostate that's kind of occluding the lumen there, and it pushes it open, and it stents it and secures it to the capsule of the prostate. And it's really as simple as this diagram makes it out to be. And those stents stay in there, and they hold that compressed. And the data at kind of 5-7 years has been very good in terms of low retreatment rates and good success. So here's a little video that just kind of shows that in a little more detail. So this is either with you asleep or partly sedated. We go in there with a little scope, and we're able to place these stents, and you can see it holds it open and secures it. And it's amazing. We really instantly, you can see the difference. And so I know that this is going to work for you. And but it does, not all prostates are conducive to this. And so that's why that workup where we do that cystoscopy, where we look inside and see if you'd be a good candidate. And that's the goal here, is to kind of open up that channel. So that's Urolift. Another treatment option that's kind of in that class of the minimally invasive is called Resume. So this is a newer therapy as well. This is one I do here in the office. So it's steam therapy. So steam is injected into the prostate, and over time that steam will kind of kill that prostate tissue that's obstructing things, and your body will just kind of reabsorb that. I do that here in the office. We use a little bit of oral sedative and some local numbing medication. And most guys do well. I usually do send my patients home with a catheter for a few days, just to kind of help with some of that irritation from the steam. But it's usually in there for about 3 to 5 days. You kind of come in and out. I do have someone drive you just because we give you a little bit of sedation. But most patients have been doing very well. And within 4 to 6 weeks, their symptoms are much improved. And similar to the UroLift, very low rate of the sexual side effects and very low retreatment rates at kind of 5 years moving out. So here's kind of an image here where that steam's injected into the prostate and it kind of helps open it up. So moving on to so those are we have medications, we have our minimally invasive options, and then kind of the more kind of gold standard classic surgical procedure. The one I do is the TURP, the transurethral resection of the prostate, the Roto-Rooter, as some people will refer to it as. And, this is really the gold standard for kind of resective procedures. It has the lowest retreatment rate, great, highest success overall, but it does have some, greater side effects. With that comes the increased side effects. It's usually an overnight stay in the hospital. You will have a Foley catheter. There's some concerns with bleeding. There will be some ejaculatory dysfunction, a very small rate of incontinence or leakage afterwards. But another option, and kind of depending upon what things look like on the inside, the size of the prostate, all that stuff that I do in the workup, we decide which procedure would be best for you. But all have very good success rates and, really improving quality of life, as well as preserving bladder function and ultimately kidney function. So here's kind of a picture. So similar, and with all of them, the goal is really just to kind of open up this channel, and there's just a lot of different ways you can go about it. So that's the benign, the non-cancerous side of the prostate and issues that we see and things that are available to you. So I'm going to mention briefly, we're going to talk about prostate cancer. So prostate cancer is the most common solid malignancy in men. 1 in 9 men will be diagnosed with prostate cancer. I tell patients all the time, if you live long enough, you're going to get prostate cancer. But the goal is to try to find the ones that are going to affect your life, affect your quality of life, and deal with those. There are some groups that are at increased risk of prostate cancer. So people who have a family history, so a father, a brother who have prostate cancer, as well as African-American men are at higher risk. There's really no symptoms of prostate cancer usually, and it's different than the symptoms that you have from the BPH. You can't have both, but usually, like I said, prostate cancer is kind of on the outside, and it really is most often asymptomatic. So the best thing that's out there is screening. I'm not going to get into all the controversies of screening, but I do recommend screening. And so, the takeaway for prostate cancer from this talk is, just talk to your physician about it. See what they have to say about it, how you feel about it, or come and speak with us in the urology department, and we'll be happy to talk to you. So what is the prostate cancer screening? So it involves that digital rectal exam as well as a blood test called a PSA. Who should be screened? So men age 55 and 70 is what our societies recommend. Before 55 for the higher risk groups, or if patients are overly concerned, and it can be extended past 70 for healthy patients who have a longer life expectancy. And screening can be done yearly or every other year. So if there's an abnormality on the physical exam, you have an elevated PSA, what does that trigger next? Where do we go from there? So kind of the classic is a transrectal ultrasound guided prostate biopsy. So that's an office-based procedure with the ultrasound probe within the rectum, where we can measure the prostate, we numb up the prostate, and then we sample some cores with a biopsy needle where prostate cancer tends to live. It's not the most comfortable of exams, but it's very well tolerated. Risks, the discomfort of the exam, you may see some blood in your stool, your urine, and your ejaculate, which can last a little bit. And there's a small but serious risk of infection, so we give all of our patients antibiotics prior to the procedure. Another thing that we offer here at university hospitals is MRI of the prostate. So MRI is very good at looking at high-risk prostate cancer lesions. And if we see anything abnormal, we can target those areas with a biopsy using what's called a fusion biopsy. But if it's negative, that may be reassuring. We can say, oh, we'll just kind of monitor things, or we may proceed with a biopsy depending on that individual discussion. One of the issues with MRI is insurance companies do not like to pay for it. We do offer a self-pay MRI, so it's around $200 here at UH, which is a really great tool. And we use that a lot in our prostate cancer patients. So, if you go through that, if you have a biopsy, it does come back prostate cancer. I'm not going to go into great detail on all these, but kind of what are some treatment options that are out there? So active surveillance is a treatment option where we say, we're going to treat your prostate cancer, but we're not going to do it right now. We're going to, that your prostate cancer is not going to, there's no evidence that it's spread anywhere, that it's going to do anything. We can monitor things and prevent some of the quality of life issues that go along with treatment for a few years, but we're going to plan to treat your prostate cancer in a few years. The active treatment options are radical prostatectomy, where we remove the prostate and some of the tissues around there. The radiation therapy, both of those, have high cure rates. The goal of prostate cancer is really to cure you of prostate cancer. And for some men, we just say, watchful waiting. You have prostate cancer, but it's never going to affect your quality or quantity of life, and we're just going to kind of leave it alone. All right, so I'm going to try to wrap up quickly so we have time for questions here, but I can't give a men's health talk without talking about erectile dysfunction. So what is erectile dysfunction? So it's really just the inability to achieve or maintain an erection satisfactory for you. So it may differ for guys. It may just be it's trouble obtaining, maintaining, may not get as hard, last as long, whatever it is. If it bothers you, that's erectile dysfunction, and you're not alone. This affects men of every decade of their life. Young guys, middle age, as you get older. And it says 50% here, but it's probably even higher in terms of, overall prevalence. So what may cause erectile dysfunction? So, diabetes, hypertension, obesity, high cholesterol, smoking, all of these things can affect blood vessels and nerves. So, it affects your heart, it affects your penis, it affects all of this. And, can really, to get a good erection, you need blood flow into the penis. You need to be able to kind of trap it in there. And with any of these, and a variety, may just be the disease, but it can also be some of the medications you're on because of that can affect your ability to obtain or maintain an erection. Here's just a diagram. I don't know how well it projects, but the blood vessels to the penis are smaller than the ones to the heart. So it's not something that you should put off either and say, I got some erectile dysfunction, but, I'm older. It's not a big deal. This may be a warning sign. This is the kind of the canary in the coal mine of something maybe going on with your coronary arteries. So that you're at higher risk from the onset of erectile dysfunction to have a cardiovascular event. So it's worth talking to your primary care doctor or talking to your urologist. A lot of times I'll send you to a cardiologist to get risk assessment. Because as much as, we care about our erections, if your heart's not ticking, then you got bigger issues. So what are some treatment options that are available? So anything that's good for the heart, good for the body. So exercise, weight loss, smoking cessation is good for erections as well. What are some medications that are out there? So the pills, the Viagra, Cialis, there's injections, there's suppositories, there's a vacuum erection device, and then penile implant, which is a procedure I perform. So the oral medications, so they're not going to just give you an erection, but they help to increase the blood flow, help you obtain and maintain a successful erection. It does require stimulation. It's best taken, but depending on which one you're taking, like the Viagra is best within 30 to 60 minutes of anticipated sexual activity. It's best on an empty stomach. The Cialis does stay in the system longer and is not as affected by that. But these tend to work well for guys. Most guys tolerate them well, may cause a headache, a little bit of reflux. These are much cheaper than they used to be, so we have ways to get them for less than $1 a pill, when I know they used to be very expensive. There's injection medication where you can inject medication directly into the penis. I use this a lot in kind of post-prostatectomy procedures. And sometimes we'll have you come into the office. We teach you how to do this. And we can put an ultrasound probe on the penis and look at the blood flow and see how well you respond to it. It works in kind of a slightly different way that the pills do, so you don't need as much of your own input. But it does require you to inject your penis every time you want to have intercourse. So a lot of patients are not happy with that process. Penile implant is a procedure I perform where we put in a device to kind of help recreate a natural erection. So there's cylinders that go into the erectile bodies, excuse me, a pump that's down in the scrotum, and a reservoir. It's all concealed. And it's outpatient surgery. It takes about an hour. You go home the same day. Patient partner satisfaction, some of the highest of anything we do. There are some risks with any surgery, pain, bleeding, infection. It's all very low. But put in well, healed well. It is a great device. It's a great surgery, and it's a really good option for a lot of patients. So I think I did it. I think I left us time for questions. I know that was a lot, but like Mark said, this will be emailed out again, so you can review it, or please reach out to us, call. We are available for in-office and telemedicine visits. We're doing everything here at UH to make sure it's a safe environment for you to come in. We're wearing masks. We're doing virtual kind of check-in where you can check in from your office and from your car and go directly from your car into the exam room. So we want you to feel comfortable coming in. But also, if you want to see us from the comfort of your home, we have telemedicine visits, and we can set that up. We have evening hours, weekend hours. We are here for you guys, and we are happy to take any questions. And thanks again for logging in.
Dr. Loeb and Anna, thank you so much for that informative presentation. We'll jump into some questions now, and just for the rest of our attendees, you'll see the Q&A function at the bottom of the screen. This is where you can type them in, and if you so choose, you can select the anonymous button as well. Our first question is, I'm a 73-year-old female with nocturia 2 to 3 times in an 8-hour period. My lab work shows no infection or diabetes. Is there anything that can be done for this?
Yes, definitely. If you would come into, let's say, come into the office, or if we would have an appointment, we would do an exam. We would check to see if there's any prolapse, anything, if your bladder's coming down. We would do a bladder diary, see what kinds of beverages and foods that you're eating during the day and at what time you're eating them. We would make sure that your bladder's emptying appropriately. And then, we would look at the treatment plan. We would go through the behavioral modifications, consider pelvic floor physical therapy if that is an option that you're interested in. And then we would look at a couple of medications. And there's, several great medications that we could give a try. And then from there, we had those procedures. I will tell you that PTNS, the procedure I do with the kind of like the little needle, like the acupuncture type treatment, works very well. And it really starts with nocturias, where it helps women when they're getting up at night to void frequently. So.
Our next question is, is the prostate more relaxed at night? Urine flow is much slow stream first thing in the morning, and then normal urine flow during the day. He doesn't need to get up at night.
Yeah, no, that is a common complaint. It could be a couple of things. A lot of times your bladder will fill up. So as you get older, you do make more urine at night. And then also when you're lying flat, a lot of that fluid that's in your lower extremities will kind of come back, so you can make more urine. And if your bladder is very full, sometimes it can be hard to kind of contract and get things going. And that's why a lot of times that first urination in the morning can take a little bit longer. It just doesn't feel like the stream's as good. And then once you kind of empty the balloon throughout the day, you have a better stream. So I'm not saying you got to get up in the middle of the night to urinate, but sometimes maybe cutting down some of the fluids at night, getting your feet up before you go to bed to get some of that fluid back in the system and urinate a little bit more before you go to bed can help it. But it's really of no, it may be an early sign that maybe you got some enlarged prostate, but it's usually not a more worrisome symptom.
And our next question for you, Dr. Loeb, is, my husband has had 2 urolift procedures, but is still producing stones in his bladder. Do you have any recommendations?
Yeah, I mean, so, stones in the bladder can be it's kind of a different process than stones in the kidney, but it's usually he's not emptying the bladder all the way. I mean, what I would do if that story, if he came and saw me, is I would probably look back inside again. Sometimes the urolift, depending on where they're placed, they could be what we call like a nidus, or kind of a source for the stones if they're too close to the bladder, and stones could be forming there. Or it may just have still a very large prostate, and sometimes that TURP procedure may be conducive to kind of help open things up and get things draining better, so he's not producing those stones in the bladder. So yes, there are things you can do, but it just require a little bit more investigating.
Our next question is, I've been advised or suggested for either TURP or Resume. Please tell me if one or the other is best.
Yeah, so I mean, that's a great question, but there's a lot of things that go into it. So it's kind of what you're willing to accept. So in terms of potential side effects, do you want something done in the office, or do you want to stay in the hospital potentially one night? Retreatment rates, are you willing to accept maybe a 5 to 10% chance that you need an additional procedure in 5 to 10 years, or do you want this to be kind of your last stop? Are you concerned about erectile or ejaculatory function? So all of those things, and depending on this, the size of the prostate as well, but really, what are your goals, and what side effects are you willing to accept? I do both procedures. I think they're both great, but I don't think one's better than the other overall, but I think having that discussion and kind of individualizing what your goals and what you're willing to accept would allow you to kind of come up with the best option. So I know I'm hedging a little bit. I'm not going to answer your question directly, but I think they both could go very well.
Next question is, can ED occur even without other issues like diabetes, blood pressure, et cetera, and just happen naturally at an older age of 70 plus?
Yeah, so I mean, I tell guys, aging does not cause erectile dysfunction, but all the other things that come along with aging do. So yeah, I mean, even healthy guys, just sometimes the elasticity of the blood vessels just isn't there. There's a process called venous leak where you can get blood flow into the penis, you can get an erection, but it just never gets firm enough or lasts, and that's very common. And a lot of times we can't really point our finger at, or this is the culprit. It's just kind of happened over time. So yes, even just we call it kind of idiopathic, or without a discerning cause, you can still get erectile dysfunction.
Our next question is, there are ads in the Cleveland paper that promote ultrasonic treatment for ED. What is your opinion on this approach?
Yes, I'm glad someone asked that. So these clinics they're marketing masters, and there's ads everywhere. So shockwave therapy, they'll say it's FDA approved. It is FDA approved for a different indication, and it is not for erectile dysfunction. There may be some role for very early erectile dysfunction. So maybe some guys who are initially starting on pills, but it's all experimental. So my standpoint, the standpoint from the sexual medicine societies, is to avoid these places unless you can get into a kind of a clinical trial. I would not recommend spending the thousands of dollars that these places are asking for, because their success rates are not as good as what is marketed. There's no scientific evidence to suggest that the results are that good. There may be a role in it, but I think it's just too early to know. So I would avoid going to those places and come and talk to us. And a lot of times we can do similar things, but really with through your insurance, not with cash, and really in more of a controlled setting.
Our next question asks, would you explain the cause and treatment of cystoscopy? Sorry.
I'm sorry, what?
Would you explain the cause and treatment of cystoscopy? You may have to help me with that pronunciation. Cystocele.
And I'm trying to.
Maybe a cystoscopy, is that what you're asking? That's the treatment that's the part of the evaluation for men or women, where we put a small catheter in your bladder. It has a light on the end. Dr. Loeb does the procedure there in the office. and he can take a look in there and see if there's any cancers, tumors, polyps, anything that could be contributing to your symptoms. I hope that answers.
Yeah, if maybe that person could resubmit that question, perhaps. Our next question is a 50-year-old postmenopausal woman said, my libido is non-existent, new development. Intercourse is extremely painful and products like KY don't help. Are there treatment options that are safe for someone with a high risk of breast cancer?
Yes, there are. So we would have you come in, we would do an evaluation to kind of tease out which, we would see which concerns are the worst for you and start with those. For libido, there is a medication that's been on the market now for about between 2 and 5 years, and it's called flibanserin. That's a newer medication that can be used for libido. There's also testosterone cream that can be used. And then also there's different therapies as well that can be, a part of that. And also there's devices too, actually. For the pelvic pain, we would want to do an evaluation and examination and see, is that pain related to a neurological type of problem? Is it a skin issue? Is it a musculoskeletal type issue? And from there, we would determine if it's something that we can treat, with, let's say, a vaginal suppository that can help to relax those muscles until we can get you into some therapy. There's also devices that can be used to relax those pelvic floor muscles, because sometimes women, they carry all of their stress in their pelvis, just like some people carry their stress in their neck, and it gets all knotted and tightened up. Or is it something maybe related to childbearing that, your pelvis is off and maybe you need to have it adjusted, and that can be done by the pelvic floor physical therapist. So do not give up. There's definitely treatment options.
Great. And our next question is, I have a rapidly increasing PSA, but still within the normal range. Should I be concerned? What do you recommend?
Yeah, so it depends kind of on your age, your risk factors, family history, things like that. So, speed of progression is important. Is it one big jump and then come back to normal, or is it a steady rise? So sometimes, if it is continuing to rise, depending on your age and things like that, you may want to investigate with either an MRI or, you can still biopsy when it's below 4. It's kind of what we use classically as the, but, with prostate cancer, it's really nothing that, even if you got diagnosed with prostate cancer right now, your chance of dying from prostate cancer in the next 10 years is almost 0%. So it's something that, does kind of afford you some time. It's something to kind of keep an eye on, but if it does continue to rise, it probably does warrant a discussion about doing some more investigating.
Great. Back to the question we had before, our person is asking for cause and treatment of a bulge in the bladder into the vagina.
Oh, it's cystocele.
Oh, it's cystocele.
Yeah.
All right.
So that is that's when your bladder herniates into your vagina. So if you can kind of imagine this is your vagina, or like, let's say this is a sock, and if it's like upside down the sock, if you can pull down on the part of the sock, that's kind of how a cystocele occurs. It's kind of like a herniation. And it can happen on the front with the bladder. It can happen in the back with the rectum. Treatment options for prolapse are, monitor if you're not getting urinary tract infections because of it, if you're able to empty your bladder appropriately, it's not putting pressure on your kidneys, if it's not bothering you. Usually it's not painful bladder prolapses. Then secondly would be a pessary, which is that device I talked about a little bit earlier. It's a silicone device that can be placed in the vagina. You slide it in sort of like a taco, you fold it in half and then it opens up, and that holds up the prolapse for you. It just needs to be taken out and cleaned at least every 3 months, but frequently I've taught women to take it out much more frequent than that. I had one lady, she was 95 years old and she had a cystocele, and I fed her with a device that a pessary that she could remove herself, and I see her like once every 6 months or once every year. And then lastly would be surgery. So we have a way of surgically, a couple of different ways. They can do it robotically, or they can go through the vagina and repair that prolapse. And we have, very good success with that as well. I hope that answers your question.
Our next question is, this person had prostate surgery a couple years ago and it has injured their legs, has had surgeries. Their therapy has stopped, but they've started riding an incline bike. So they're wondering if this would do any potential damage.
So damage to their erections?
Maybe the prostate surgery.
Yeah, I mean, exercise, sitting on a kind of a bike, things like that, it probably wouldn't damage anything. I mean, there is some reports out there of kind of people who do long distance cycling. You may have some erectile dysfunction associated with that, but I think the benefits of the exercise and all of that probably outweigh any direct effects. But in terms of just using the bike, I wouldn't worry about damaging any surgery that you had. I think it's good to get the exercise, kind of however you can get it.
Great. Our next question is, I've been taking supplements from Life Extension, Pumpkin Seed Extract, Men's Bladder Control, and Palmetto Guard. Seems to be helping as I stopped taking Temsulo, except for urine flow. I take one capsule, which is helpful. Should they continue on those supplements?
I mean, the supplements have been around forever. I mean, a lot of the science isn't behind it, but anecdotally, or people, it seems to be working for you. Sometimes you don't know exactly what's in there. So in terms of risks, they're counteracting, other medications. So it's kind of take at your own risk. And while I can't really endorse it or say you need to come off of it, but just know that it may not be as pure studied as some of the other stuff that's out there. But sometimes with those procedures I talked about, the Urolift or a Zoom, a lot of times the goal is to get you off medications completely. And so if you're looking to kind of see if maybe that would be an option too, that's another avenue that you can investigate.
Our next person asks, they've been taking Viagra for ED, but it stopped working. Should other pills be candidates to solve this problem, and are they likely to work adequately?
So yeah, I mean, a lot of people will switch classes. I find that if you're switching because it didn't work well, it usually you don't have that much success. It may sometimes switch into Cialis or things like that. I find the guys who have better success is if you're switching due to a side effect. So Viagra can cause a little bit more of a headache, and the Cialis maybe cause a little bit of back pain. It's worth a shot to try. And if not, then talk about maybe some more of the advanced options, the injections, the penile implant, things like that.
Our next question is that this person finds that problem days are with constipation. They have effect on the urination. Is there any help except to prevent the constipation?
I mean, I think, working on the constipation will drastically improve your urinary. So, making sure you have soft bowel movements every day. A lot of patients take a cap of Miralax or Metamucil once a day, just kind of keep things moving through, hydrating really well, drinking water.
I want to chime in on that too. I think a lot of times people wait and they take something when they're constipated instead of trying to be proactively preventing it. And oftentimes I see with ladies, that's where we have like the urinary tract issues and the, the issues with their bladder and their urge incontinence and that kind of thing. But just actually understanding how those medicines work, that they're more for prevention versus waiting until you have the problem.
Great. Thank you, Dr. Loeb and Anna. We've about run out of time today. Again, I want to thank all the attendees for tuning into our presentation. Again, you will be receiving an email maybe late this week, early next week with a link to this presentation you can watch again. along with the contact information for Dr. Loeb and Anna if you'd like to schedule an appointment. Dr. Loeb or Anna, any closing comments?
I just wanted to chime in with what Dr. Loeb said earlier. The people here at University Hospitals are making it incredibly, your safety, the highest priority with the pandemic concerns that have been going on. And like he said, we have ability to, bring you in just in time for your appointment. We have you call up and make sure that the waiting room is clear. You come in, you're taken to your room. Everybody is masked. We're doing extra cleaning, and it feels very safe. I have children. Dr. Loeb has children, and I feel very safe working here. And just want to reiterate that.
Again, thank you, attendees. Thank you, presenters. It was a great talk today. We hope everyone stays safe, and you can find more talks on uhhospitals.org. We'd like to see you in the future. Thank you.
Thank you.
Thank you.